basically patellofemoral arthroplasty. When to do it? The most common indication and the patient selection is the key. Patient selection is the key, means there should be an isolated patellofemoral arthritis with failed conservative treatment, with failed response to bone conserving options. So when not to do it, like if there is a patella baja, or if we are having a doubt that there is a other compartment involvement, or if it is an infective or inflammatory arthropathy. So how common it is? It is documented in one of paper that patellofemoral arthritis, the anterior knee pain due to patellofemoral arthritis is almost 10 to 20% of patients over the age of 40 years, and it is more common in females. So the etiology behind is it multifactorial. So female sex, high BMI, previous trauma like patella fracture or some quadricep tendon rupture in some patients with congenital or development anomalies like patella alta, the trochlear dysplasia, and weakness in the weakness or hypoplastic vastus medialis. So to diagnose it clinically, that is the most important step, that diagnose it clinically and radiologically. Basically, patient is having an anterior knee pain which is aggravated by descending and ascending stairs, then hill climbing, kneeling or squatting position. Basically, we have to palpate for the tenderness in the medial facetal joint, medial facet or a lateral facet. Then we can see the crepitus. And one test also called as Clark's test. If you ask patient to extend from the flex position and we press the patella down, there is a crepitus or pain, that is a Clark test. In long-standing cases, we generally found quadricep weakness. So on radiologically, we need X-ray, that is the most common view, that is standing anteroposterior view, to rule out any other joint, other compartment involvement. Then the standard tunnel view at 45 degree, which is called as Rosenberg view. Rosenberg view is for to see the posteromedial compartment, tibiofemoral compartment, posteromedial tibiofemoral compartment. And then Merchant's view to diagnose the patellofemoral arthritis and even to grade a patellofemoral arthritis. Sometimes we have to do CT to see any trochlear dysplasia or some changes in the femur. And in case of a doubt, we need to go ahead for MRI also to look for other compartment involvement, and even the diagnostic arthroscopy may be needed sometime. So the classification, which is based on Merchant's view, here we can see stage 1 is like the gap between the patellofemoral joint is more than 3 mm. If it is less than 3 mm, stage 2. Then stage 3 is the bony contact, but it is very mild. And the stage 4, like sometimes subluxation or global contact. Other classification, radiologic classification also exists, which shows either it's a lateral facet, medial facet, global involvement, or the trochlear involvement. The treatment options available are conservative and other like surgical. Surgicals are soft tissue alignment procedure, osteotomies, then autologous chondrocyte implantation, some mosaicplasty, and all those. And what we are interested in, patellofemoral arthroplasty. Basically, the indication is only isolated patellofemoral arthritis with failed conservative and bone conserving options. What history suggests is first in 1950, McEver used first implant which is abandoned due to excessive wear in the trochlear groove. In 1970s, the other implants came, which are also called as first generation resurfacing implant. The design is more of an inlay design where they replace only one cartilage. The design has its limitation and very high failure rate. Few are like 17 to 78% failure rate. The other second generation, or we called it as third generation onlay design, comes in 1990s, where all these designs are available in symmetrical trochlear implant or asymmetrical. The best implant or the best survivorship in the literature is Kanematch custom patellofemoral replacement, survivorship of almost 100% at an average of 11.3 years. Yeah, give me some minutes.
Already running short of time.
Sure. I will directly jump to the surgical technique. Approach is same as midline patella approach and all those things we are seeing from yesterday. So hip center calculation. The most important thing is the wide side light calculation in a surgical technique. That is, we have to flex the knee at 90 degree, place the tip of probe at the highest most central of the center part of the internal condyle notch, sloping downwards on the posterior side. So trochlear mapping surface, whatever information we give to the robot, it will size the implant accordingly. So the mapping is most important thing. Then implant planning, here we have a different steps than uni. Basically, we have three views: articular surface, cross-sectional, and cut surface view. The most important steps in implant positioning, that is the most important keys. The rotation, it should be like anatomical axis considering the Y side line, and the posts are fixed inside the articular surface, and the distal tip should be sitting inside the notch, so that there will not be any the transition zone should be smooth, so that the patellar tracking will be good. And the robotic boring, finally the patellar preparation, which is routine for like a conventional trachea, and the final stage implantation. So these are one of the x-rays we did it in for patella-femoral arthritis. In literature on robotic patella-femoral arthroplasty is very few. One of the literature is Turkas, which shows 30 knees and a mean follow-up of 9.9 months showed no signs of malalignment. We have only done 4 robotic PFA till date with a mean follow-up of 12 months without any complication.